So we'll now begin the stroke education session for New Hampshire Critical Access Hospitals, presented by members of the New Hampshire Stroke Collaborative. The agenda for today's webinar is shown here. There will be 3 content sessions following this brief introduction. They're not in any particular order as it was based on the availability of presenters. There will be 2 5-minute breaks to allow participants a bio break, as well as to get up and stretch your legs. The remaining time will be allotted for a discussion among the presenters and attendees. Questions for the presenters will be encouraged during each presentation as well as during the discussion period. You may ask your questions in the Q&A box. Please ask the questions to all presenters or everyone so I can be sure it's addressed. If you would prefer to speak your question, you can request to be unmuted by typing in the chat box to Alia Hayes or all presenters, and I will introduce you and then unmute your line at an appropriate time. During the discussion section, lines will be unmuted at the request of participants in the same fashion. So today's session is brought to you by 4 members of the New Hampshire Stroke Collaborative, or NHSC as I will call it from here on in. My name is Alia Hayes, and I'm an executive board member with the NHSC, and I'm the Rural Health Manager for the Rural Health and Primary Care section at the New Hampshire Department of Health and Human Services, Division of Public Health Services. I have met some of you through the work I've done with New Hampshire's critical access hospitals, but certainly not everybody, so I look forward to further interactions. I'll be introducing today's session and moderating throughout. Dr. Tim Lukowitz is the NHSC Medical Director and a neurologist at Dartmouth-Hitchcock Medical Center. He will be speaking first today to discuss CT and CTA for acute stroke analysis. Following that presentation will be the first of the 5-minute breaks. Kathy Danforth is an NHSC Executive Board member and the clinical nurse leader for the stroke and sepsis programs at Wentworth Douglas Hospital. She will be speaking about TPA administration. Sue Barnard is the NHSC co-chair and works at the Elliott Hospital Coumadin Clinic. She will be speaking about interfacility transportation concerns and communication. We'll have a second 5-minute break following Sue's session and prior to the discussion time. So who is the New Hampshire Stroke Collaborative? We are a group with representatives from across the spectrum of stroke care. Our mission is that we are an interprofessional group that creates, enhances, and advocates for advances in stroke system development and stroke care in New Hampshire through evidence-based education and open dialogue with stakeholders and stroke care providers. Our vision is to prevent stroke and promote the best possible outcomes for stroke. In terms of what the New Hampshire Stroke Collaborative does, we provide outreach and education around stroke. In a typical year, the collaborative runs workshops and conferences for professionals across the spectrum of care. And we invite you to participate in monthly meetings held on the first Monday of the month from 1 to 3 p.m. to help us improve the stroke system of care in New Hampshire. So how did we get here? The reason we're holding this session today is because the collaborative recognizes that the conferences and workshops held in the past have been mostly inaccessible for those working in rural hospitals. Prior to COVID-19, we were in discussions to try and figure out when and where collaborative members could come to you. Keith Shute was instrumental in getting today's session together, and I would like to acknowledge Dr. Shute as well as each of the collaborative members for dedicating their time and energy to today's session. I also want to thank every one of the participants on today's session for taking time out of your workday or home life to attend. The goal for today is to provide education for those of you working in the rural communities of New Hampshire and to see how the New Hampshire Stroke Collaborative can be a resource for you to improve the stroke systems of care. If you would like to get involved in the NHSC, please email me at the email address shown here and state that you're interested in receiving notifications of our meetings. Teleconference options are always available, even when there are not additional measures being taken for safety around the pandemic. And here is additional contact information for me, and please don't hesitate to reach out with any questions or feedback at any time. And now it is my pleasure to introduce Dr. Tim Lukowitz.
Great, thank you. I welcome the opportunity whenever possible to meet with you people other than on these harried transfer center calls. So are you seeing my PowerPoint okay?
Mm-hmm.
Okay, so today I wanted to speak about the value of CT and CTA in acute stroke, kind of get back to basics. And I believe all of the New Hampshire hospitals have the ability to do CTA. There are some that may not have the ability to do it overnight, and that's something that we should discuss at some point. Let me just advance here. Okay, so I have no disclosures. I don't use any of this artificial intelligence software that might get discussed at one point at the end. So a summary of the value that I want to highlight for plain CT and CTA. One is that it can identify the large vessel occlusions, and if the CTA is done up front with the CT, it can definitely reduce the door in, door out times and the whole overall process. The CT acquisition is actually very quick, less than 5 minutes, and it's important to know that you don't need the fully processed images for acute decision making. And it could definitely help identify stroke mimics as one important data point if the tests are negative. So of course, this is not perfect. Not every stroke has a CT or CTA abnormality, but it can help in some cases where it's unclear what's going on. It can definitely identify the vascular basis of acute vertigo in many cases, which are difficult cases in the emergency room. It may help reduce unnecessary transfers sometimes. And it can be better than MRA for showing aneurysms, cerebral vein thrombosis, and characterizing complex carotid plaques. So I'll show you some examples of that. Now, this is an algorithm from the American Heart Association that the state of Massachusetts helped develop, and we were able to use it with permission. So I wanted to walk through this. This highlights the importance and the shift in thinking about imaging for acute stroke towards doing CTAs more rapidly and more frequently. So it starts with any suspected stroke that might be a candidate for thrombolysis or thrombectomy or both. And it's within 24 hours now because of the extended time window. And we use a clinical score to help be somewhat selective in doing CTAs. So we use NIH stroke scale 6 or greater, or the newer EMS scale that you're hearing about, the FAST-ED score of 4 or greater. These are very helpful in predicting whether someone's going to have a large vessel occlusion that will be treatable with a procedure. So if those are all yes, then it's recommended that both a CAT scan and a CTA head and neck be done together. And if you look over in the box here, it's recommended that you try to avoid taking the patient back and forth to the scanner whenever possible. And it's not recommended now that you wait for the renal function tests if there's no known history of renal dysfunction. If it's a known history of severe renal dysfunction, then there is a discussion that usually needs to take place, and then documenting the small risk of a worsening nephropathy that might require dialysis. So if we have a patient who looks like they're a thrombectomy candidate and they have a history of renal dysfunction, even severe, we usually will end up proceeding with the CTA after that brief discussion is done between ourselves and radiology and the patient's proxy. And if they're a candidate for IV TPA, then you don't delay and you administer that, and then you're getting the results of the CTA at the same time you're starting that, and then you're reviewing the criteria for thrombectomy and considering transfer. So that's the basic recommended algorithm that's happening more and more in our region. This is a guide that we we developed it last year that uses that algorithm, and it'll be handed out, I think, with the recording at a later date. So it includes the algorithm and some technical points to make the scans better, and I'm going to mention these. So I was going to give you a couple of cases. This one's very recent. It was a 41-year-old, and I'll just say far northern New England. And I think it brings up some of the points where the imaging may be very valuable and not totally appreciated how valuable it can be. So this was a young man at work, was found unresponsive, and I think the diagnosis was not clear. He was there for 5 hours before we were called. He was thought to have altered mental status, and they did a lumbar puncture that was basically normal. This was just a mild traumatic tap, and he was given Ativan. He was thought to possibly be having seizures because of some tremulousness, and he had some THC in his drug screen, and his CT was thought to be negative. And then later in the same discussion, this is our log with our transfer center that we get to review some of the details. So we're talking on the phone to our transfer center. We're seeing this, and then we're put on the phone with you guys. So he was given the Ativan. He was found to be unable to follow commands, carry on a conversation. He had a history of drug abuse, but he was clean for 2 years, and they thought a Bell's palsy deficit on the right side upon arrival, but it seemed like it had resolved. And this is just a CAT scan that was thought to show no acute abnormality. So this is the CAT scan from earlier that day. That had been done about 4.5 hours before we were called, and it was thought to be normal. And it's subtle, but on this initial image, when you look at these a lot, you can see a definite change that I'm going to highlight here. Here's a higher up view. So one of the things I'm going to show is the importance of stroke windowing. Now this is more for your radiologist, but this is a simple thing that just allows you to look at a CAT scan correctly, just like you would look at a chest CT with the right windowing. The default windowing is not the best for seeing acute ischemic stroke changes. So now if that's windowed with more contrast, this area here underneath the insula and the basal ganglia is very asymmetric. So this is something you learn to see with middle cerebral artery occlusions. So this is a definite change there. Higher up, he's a young man, so he can see the sulci very well, and it's not possible to see the cortical differentiation here. So it looks like there's a pretty large early changes of a stroke here from the left middle cerebral artery. The other thing is if you window it, you can see this hyperdense middle cerebral artery that wasn't appreciated. So this right here, this is a plain CT now. So all of these things were part of the original regular CAT scan. So he eventually came down. It wasn't rapid because the diagnosis when he was transferred wasn't known. So he got there around 11:40, and now you can see this very large infarct. And this is part of the CTA, and it really shows up the infarct because there's no blood that gets to the infarcted tissue, even in the capillary phase. So here's the CTA, here's the right middle cerebral artery, and then there's no left carotid or left middle cerebral artery. And here in the same study is the carotid artery showing a crescent from a probable dissection. So he was a furniture worker and never found out exactly what caused it, but probably there was some kind of trauma that had occurred. So this is his left internal carotid artery down in the neck. And so that all was visible pretty instantaneously on the CTA. A little later, he had an MRI confirming a very large infarct, and then he eventually had a craniectomy. So this is all bone that was taken out, and that allowed the brain to swell out. There was a lot of discussion because it's a dominant hemispheric stroke. He's 41. These are very difficult cases. So I'm still taking care of him in the hospital now, and he's controlling remote control. He's eating a normal food by himself. He's communicating with hand gestures. but he's hemiplegic and basically mute. So it's a tough decision, but this is what happened. He may have been possibly eligible for treatment that could have saved some of the brain if it was all recognized right away, which is difficult when people are just found like this. My next example is these patients who have sudden dizziness, who reportedly have a normal CAT scan. So this was a 47-year-old who came in. This was not as recent. He had hypertension. It was April, and he was in the bathroom. Seems like the bathroom is the place that people have strokes and get dizzy all the time. But he felt like he was on a ship. He took a shower despite that, yelled out to his wife. He got out of the shower. He felt very sweaty. He veered to the left and almost went to the ground and vomited a few times. So a few of these things here are red flags. It's sudden onset. He's veering to one side. He vomited, but it's not entirely specific. So in the ED, his vertigo seemed to mostly resolve, but he was very hypertensive. And the CAT scan was read as normal, and he was admitted to a rural New Hampshire hospital for hypertensive emergency. In retrospection, I think, again, with the correct windowing of the CAT scan, this is the CAT scan here. Here's with a little more contrast. So this is the inferior cerebellum. You can see the two sides are very different. So this is exactly what you're looking for in a patient with acute vertigo, an infarct in the inferior cerebellum. So if you're looking for it and you window it, you can often see it. Now, if that wasn't there, I'm going to show you another case. It doesn't mean he doesn't have a stroke, but it's very helpful. And these people can get into trouble with edema. So it's important because sometimes they'll get the CAT scan and then they have an MRI days later and then they're about to herniate. In this case, he stayed there because that wasn't seen. And there was a discussion about him going home even because he was feeling better. But he reported some ongoing neck and head pain, and he felt dizzy whenever he got up. In fact, here's, these automatic beds that adjust whenever you move. It made him have vertigo again because it adjusted his position in bed, and he was about 300 pounds, so that constantly was happening. You wonder why patients are sleep deprived. That's one of the reasons in the hospital. The ICU attending then noted that he had nystagmus that hadn't been seen before, and so they did an MRI, and it confirms this large infarct in that part of the cerebellum. Often these are visible, though, early on the imaging. So that patient, I believe, he did well. He had surgery to remove part of the bone, like the next case. One other case that's similar of sudden dizziness with, again, a normal CT scan that shows that this is not an unusual event. So this was a little bit different because they specifically documented that they couldn't do this maneuver, the Dix-Hall pipe, which is to test the vestibular system to see if it might be an inner ear problem versus a stroke. And so they couldn't do it because he just seemed too weak. And he also had the CAT scan that was thought to be normal. You might see a subtle difference in this scan here. I'll window it more, but again, they thought it was all normal. Here with a little windowing, again, this is the right cerebellum. You can see that infarct in the right cerebellum, and here's the MRI. He needed some bone removed back here because the swelling was pushing on his brainstem, and he ended up doing well. This is a case I saw with telemedicine that was different because he truly did have a normal CAT scan, but he was younger, he had abrupt dizziness, and this is just showing how the CTA can really help with these cases if you're not sure if it's a vascular problem. So this here is an axial CTA, and this is the vertebral artery. Here's the one on the other side, and you can see sort of the ghost of the image there that's occluded. So there's no contrast getting into it like the other side. So that was a normal vertebral artery that's now occluded. And here on the image from front to back, you can see that there's some vertebral, but then it becomes occluded, and then it's not present up here at the foramen magnum. So that allowed me to give him alteplase because it kind of confirmed that it was an acute stroke. You could have treated him without knowing for sure that maybe it was peripheral vertigo versus an acute ischemic stroke, but that's always an uneasy situation. But this gave us more confidence as to the diagnosis. So, as you know, you probably have tried to do this more than I have, but this battery called HINTS to look for signs of a peripheral vestibulopathy is often tried, but it's really not as easy, especially with a patient in the emergency room vomiting. So this is actually the proper way to do the head impulse test, which is the key exam finding. So it's a very low amplitude, rapid horizontal movement to try to see if their vestibular system is working or not. And if it's not working, then there's a corrective saccade. So I think I have doubts about how easy that is and how accurate it is being done. And so it's just a word of caution that that may not be the basis for a strong diagnosis. I guess if you've done it and it's a very obvious abnormality of being abnormal, then that can help you establish that it's a peripheral vestibular problem. So these are the other things you're looking for. Skew deviation, which is a vertical misalignment, which is often seen with a medullary infarct, which is part of one of the most common causes of acute vertigo that's from stroke. So the next are just a couple of other general points about what CTA can show you. So obviously it demonstrates a normal and an occluded left middle cerebral artery here. So I think this can be tricky and these can be missed. This one looks kind of obvious, but with CTA, you often fill the distal vessels and it might just be a short gap. So it's not like everything is occluded downstream, and it might just be a short gap. So people can miss that short segment of an occlusion there. So especially if it's in these more distal branches here, it can be very difficult to see those. Another purpose is looking at the collateral, so that distal vessels past an occlusion. So it's been shown that these collaterals, which are getting there through the other arteries, like the anterior cerebral, the posterior cerebral, and then that's getting blood retrograde back to the tissue, that's obviously very predictive of how well someone is going to do with a thrombectomy, even out to 24 hours. So here's a patient where it's showing if you do a modified CTA, which is recommended in our region and in that Massachusetts protocol, to do at least 2 phases, where you do a delayed one where you actually can see the collaterals fill in. Right away here, if you do it immediately, they're not showing up. If you wait, you start seeing them. So this is something that can indicate that a patient's going to benefit from a thrombectomy even in a later time window. Whereas this patient here has bad collaterals, and that would make you a lot less optimistic that they're going to improve, especially if you start seeing early ischemic changes. So here's a right middle cerebral artery occlusion, and there's no collaterals here, and then you wait, and there's still none. So this is a bad sign, and they're not likely to benefit from a thrombectomy, especially if it goes on a long time. This is just showing how the percentage of the collaterals, or the quality, here's a very good, a patient with very good collaterals, and this is the percentage that have a favorable outcome, almost 50% here, whereas the group that have incomplete or poor collaterals, it's a minority, about 10%, that have a favorable outcome with thrombectomy. So we see that commonly in patients. The use of CTA for carotid dissection is also really helpful. So here's a couple examples. This is a right carotid dissection at the skull base, and this you can see the normal lumen, and here's the false channel that's from a dissection, and here's the normal vessel. And this is a plain CT showing that a lot of these dissections actually show up with plain CAT scan because it's a thrombosed vessel and it'll be hyperdense. So and it'll be larger. So if you, again, this may not jump out so much, but this left carotid has a dissection. It's bigger than it should be because it has both a regular lumen and an extra lumen hematoma from the dissection, and it's somewhat hyperdense. This isn't the most dense case, but this is a left carotid dissection. So this is something that when you start looking for it, you see it more and more. And this is a case of distal vasoconstriction. So we see patients who have thunderclap headaches and don't have a subarachnoid hemorrhage, and they have a condition called reversible vasoconstriction syndrome. And CTA is excellent for that, especially if you have this side view of the anterior cerebral arteries. You can see all the little segmental narrowing and caliber changes. So this is an excellent test for that condition as well. Okay, one example of a CTA for hemorrhages that can help, in addition to looking for aneurysms and AVMs, is this finding called a spot sign. So this is a little spot like here in the hematoma that is probably the little bleeder that's causing the hemorrhage. And if you see that show up when you give contrast, it's actively bleeding and it's leaking contrast. So that's a marker for hematoma expansion. And here's a patient who has this plain head CT, basal ganglionic hemorrhage. They have this spot sign and it gets bigger. So currently, this is just a marker of the patient having a high risk of hematoma expansion and getting worse. It's not clear exactly how that should change your management. It might be one factor in deciding to pursue the most rapid transport possible, which you're probably going to do anyways with an acute hemorrhage. But they're looking at this in trials where they're giving different clotting factors to see if they can stop the expansion. But so far, it hasn't been shown to be helpful in those trials, like factor 7A, for example. So we'll see. There might be uses in the future other than just being a bad sign. One other area that I think CTA is very helpful, because in CTA, usually you'll get the veins opacified very well with a regular CTA technique. If you're looking for cerebral vein thrombosis, often they'll do one other delayed acquisition through the head to show the veins. So here's an example of a CTA. Here's arteries, vertebrals, but they're also, we're seeing the veins here. This is the sigmoid vein, which goes into the jugular vein. And then here's on an MRI, you can see the changes here. But it's very easy to diagnose this on a CTA as well. Here's a similar patient where they have a new headache, and there was a question on the initial reading of the studies whether there was an abnormal left transverse sinus. So one nice thing about the CTA part is you see the bones, and if you have a congenitally small vein, which is very common with the sigmoid and the jugular veins for one side to be hypoplastic, you can see that in the bone. So you can see the canal or the cleft here is much smaller than on this side. So that's an indicator that that is probably hypoplasia of the vein rather than a decrease in flow from some kind of acquired disease. So that's an advantage of CTV, which isn't as easily obtained with MRI. There's the normal. Okay, this is just from that handout that you'll get later about some of the technical points I'm going to bring up, why we talk about using one arm versus the other, things like that. So this is an example of a face-on view. Here's their trachea, and this is their aorta. And this is one example about why we prefer the right arm for the injection for a CTA. This was a left arm injection, and often one thing that can happen is because the subclavian vein goes across the great vessels coming off the arch, it obscures the origins because it's like a streak of contrast here that you get often. You don't get that if you inject the right arm in the right subclavian vein because it goes right into the innominate, into the aorta, and then it goes into the arterial phase. And here's another example of why the left arm can be a problem. This is the subclavian vein between the sternum and the aorta. In some patients, especially older patients, this can be narrowed. And here, it's a tight area, stenosis in the vein here, and that leads to a poor injection. And then there's reflux up the jugular vein that you don't want. You don't want that to immediately go up one jugular vein because it'll be just this bright contrast, and you want it to get into the arterial circulation. So that's one other thing that you can see with a left arm injection. If you do the left arm and you get that reflux, it often goes into all these little epidural veins and cervical veins here. So this is just backup of the contrast where you don't want it to go. These branches off the sort of jugular vein and subclavian veins. One slide about some possible concerns people might have about safety. So if you look at the amount of radiation for a typical, this is a head and neck CTA, it's about 5 millisieverts, and it's 1.6 if only the head circle of Willis is done. A chest CT is typically 7 to 11 millisieverts from my information. It can end up being a total of 16 if you also obtain a plain head like I'm recommending and a CT perfusion with it. So this is, a CT perfusion requires one other scan. We're not routinely recommending or using CT perfusion here, but there are some hospitals that may work with centers that do use that. So if you do all of these, it can add up to a little more than a chest CT. That's about 5 to 6 times the annual exposure just as baseline for the general population, which is about 3. So it is something to consider. You don't want to repeatedly do a lot of CTAs on the same patient, and we avoid them if possible in young adults and children. Let's just go, the contrast nephropathy risk is discussed a lot, but it's actually pretty minimal in a patient with normal kidneys. And if we have even patients who are on dialysis, we often will do a CTA if it's thought to be an urgent need. So I think I'm probably going to end there to take some questions as well. And I think I'm ahead of schedule if I have it right.
You are, Tim. Thank you. So if you have questions at this time, you can type them into the Q&A box.
If there's no questions, one of the things is whether there's any issues that people would want to mention with obtaining the CTAs off hours or technical issues or delays due to checking creatinine and things like that, that we might want to help collaborate on. If you see any questions, let me know.
At this time, there are no questions.
All right, I would just mention sometimes we have delays in image sharing, and sometimes it's an issue on our end, and sometimes an issue is on both ends. But it's very helpful when you obtain these early CTAs to start getting your radiology departments to start sending the images. And then when I'm on the calls, I start asking the transfer center who talks to our film library to page me as soon as we have those. So we've kind of learned they use like a trillion between the transfer center and the film library, and we have 24/7 people in the film library doing that because we know this has been a problem that can introduce delays, but it's so much better than several years ago when we often couldn't see anything until the patient rolled in with a CD and it may or may not open. So it's dramatically improved from the past.
So there are actually 3 questions at this time, Tim. The first is, can you address the time between, CT and CTA, and is it necessary to wait at all between the 2 studies?
It depends if you have people who can be there and make a decision. So we are often there physically at a stroke alert, and we can say, all right, it's a hemorrhage, let's not do the neck. So we might save the patient some neck radiation. But often if you clinically think this patient looks like a possible large vessel occlusion, you make that decision. I get my team to make that decision before they start wheeling the patient a CAT scan. So we do a brief assessment after they roll into the ER. So this is one of the, I know there's discussion about straight to CT, which can be very good, but one of the things I like to briefly pause, make sure they have good access, and we make a decision, what imaging do they need? Because it's inefficient to send them there, send them back, go back again. So I get my residents to think, what do you need? Do you need the CTA or not? Are they safe to go? We talked briefly with our ED colleagues. If you have someone who's going to be either a radiologist who's looking at the plane head right away, then you can sometimes save some patients the full CTA. But for the most part, you're going to make the decision before they go. So if it ends up being a large hematoma, there's some value in getting the CTA to look for a vascular malformation. We see those. They often would get that later if they have a hemorrhage. So if it's transmitted, it'll save the patient getting a second or getting a study when they're transferred. So there doesn't need to be a pause. It's a brief one to set up the injector. So you'll just see them scan the plane head, then they walk in the room, hook them up, they walk out, they do the CTA. You check in on the patient, making sure their access is good. So it's a brief, I would say, couple of minutes between the two.
And I believe this is a second kind of part to this question, or additional part to the question. Is your protocol for plain CT and CTA head and neck at the same time, one trip to the scanner with no creatinine?
Correct.
Okay. And
Yeah.
then
that's if they're known to have a history of severe renal dysfunction, we then just like I said, we discuss it. We kind of have a higher threshold to make sure it's really needed, because there is a small risk of nephropathy needing dialysis, but we don't wait to get the creatinine.
And there are two additional questions. If CT study is negative, pardon me, and symptoms persist, is it reasonable to follow with MRI as soon as possible?
Yes, in general, there's some stroke syndromes, like if you might have a 90-year-old who's got a classic internal capsule deficit, you don't always have to have an MRI. So that there are cases where we don't always get an MRI, but it is very helpful in determining mechanism in a lot of these patients. The pattern of infarcts, confirming a diagnosis is very helpful. So yes.
Okay. And the last question that we have at this time is, can you please review what facilities in New Hampshire are doing embolectomy?
So we have two, Dartmouth Hitchcock and Portsmouth Regional does some thrombectomy. And then the nearest ones are outside of our state, or you probably know, Maine Med, UVM, Albany, and then Bay State and Boston.
All right. And there are no questions remaining at this time. I'll give everybody just a moment to think of anything else, and then we'll have a 5-minute break.
Ali, I just wanted to say one quick thing that Kathy is probably going to address. When if you're going to do CT, CTA, both with one trip to the scanner, you can bring your TPA there, and it can be hung after you've got a negative CT. This cuts down time. I mean, it's, you've got to be able to have someone there that's reading the CT and saying the CT is clean, but that is something that can be done as well.
Yeah, I'll discuss that in workflow of how to utilize that time between CT, CTA. Yeah. Thank you, Sue.
Okay, since I see no other questions remaining at this time, we'll say goodbye to Dr. Lukovitz, and we'll take a 5-minute break. So it's now 8:44. We'll come back at 8:50, and then we will have Kathy Danforth presenting on TPA administration. All right, Kathy, you have the floor.
Okay, thank you very much. Thank you everyone for making the time today, and I certainly welcome questions throughout the presentation, so feel free to pop them in there and we can stop along the way. I do not have any disclosures, financial disclosures, and I will talk a little bit about Alteplase TPA and its off-label use. So, why are we worried? Why are we concerned? And what's the urgency for treatment of patients? Stroke is the 5th leading cause of death in the United States, and also here in New Hampshire. But as importantly, it's the leading cause of adult disability. And that's the key piece of what we want to really work towards, is how can we really find some way to help these patients and really reduce their disability. So emergency stroke therapy. Ischemic stroke is a common and serious disease. The potential for death and severe incapacity is there, and it affects both patient, family, and the community as well. And we do have an approved therapy that's proven of value when available, and that's intravenous thrombolysis within 3 hours, and that's approved by the FDA. So as you know, we can still give TPA up to 4.5 hours, and that's considered off-label use. But it is recommended by the American Heart and American Stroke Association, and it's part of their guidelines. But what they have found, and what the literature has shown, and what we've all seen, is that success is linked to early treatment. And the guidelines from the American Stroke Association provide the recommendations for care for that early treatment. It's safe, it's effective. And today, not following some of these guidelines is actually considered not following the standard of care. So the American Stroke Association, again, been working diligently over the years. Actually, they met the goals for their phase 2 target stroke. And so they released phase 3 of target stroke. And these are some pretty aggressive goals to meet. So when we talk a lot about the timing of things and the urgency and the importance of doing this as soon as possible, this is some of the goals that they have set for us starting this year. So they want to have us achieve door-to-needle times within 60 minutes, 85% of the time. So that's up from 50% of the time of what it was before. Because what they're seeing is it can be done. We achieved it in phase 2, but also we want to improve the time to thrombectomy for those patients who are eligible. So patients can get TPA if they're going to get thrombectomy. So keep that in mind. A lot of people ask that question. It can be done. Our secondary goals are to reduce the time from door to needle to 45 minutes, 75% of the time, and then door to needle 30 minutes, 50% of the time. So a lot of work going into, let's really look at our process and where can we reduce times and improve that door to needle time and be able to get that medication to our patients. So I put this in here, and I apologize, I'm covering some of the screen up as I moved from one background to the other. But 1 in 3 Americans live an hour or more from a stroke center. You all are aware of this in your rural areas. And the death rate is about 10% higher in those areas. And this really just shows it how it is in the South, which is considered the stroke belt, that there is a higher mortality rate in those areas. So knowing that we may have some timeframes considered because of the time it gets the patient to a facility, pre-hospital management is key. And this goes back to those stroke systems of care that Alia talked a little bit about, how important it is to consider every aspect of the care. And we start with our pre-hospital management. So these are our EMS services. So you get that call, you show up to a patient, assess and manage the ABCs is something that is always done first. Initiate cardiac monitoring if this is a patient presenting with stroke-like symptoms. It's only necessary to provide oxygen if their oxygen saturation is less than 94%. Otherwise, it's not necessary to do that. You do want to establish an IV access with saline. So it was interesting because Tim really talked about the importance of having a right arm, which is preferred. If that's something that can be done, that's great. Also, if you're able to obtain labs, that's great. But it's not something that we want to delay any transport time for. Important not to give too much volume until we figure out really what is going on with the patients, and not to administer any glucose-containing fluids unless the patient truly is hypoglycemic. And that's a key thing that EMS can do, is checking the blood glucose and treating that accordingly. Now, oftentimes, and I don't know if you find this in your rural areas, we actually find it, here at the Seacoast, only 50% of our patients call EMS, those that come in with stroke-like symptoms. The other 50% come in by private vehicle. They think they don't want to trouble anybody, they don't want to disturb anybody, and if these symptoms are not very significant, that's what will happen. So we really do try to educate the public on the importance of calling EMS no matter what the severity of the symptoms are. And what I tell them is, I said, they can start treating you right away in their ambulance. They can get that blood sugar, they can start that IV, they can do that first initial neurological assessment and call ahead and let us know at the hospital so we can get our stroke team moving. So the last bullet here is determine the last known well. And it's not as easy as you think, and I'll talk a little bit more about that on the next slide. But things that are not recommended pre-hospital is interventions for hypertension unless you're directed by your medical command center. Excess fluids is not necessary, and we stay away from dextrose fluids because of the potential for cerebral edema. And we really caution oral medications to be not administered during this time because of the risk of aspiration. So commonly people want to give aspirin, but we tell them to hold off till they get there. And it's really sometimes a very subtle aspiration risk that the patient will have. So waiting until they're screened at the facility is best. Again, don't delay for transport. Get the patient as quickly as possible to the facility. But finding out the last known well is key. And the thing that we often teach is symptom discovery time is not necessarily the patient's last known well time, especially when it's someone who woke up with symptoms. And our acute stroke treatment is based on the patient's last known well time. So it's critical that we really narrow that down as close as possible to the actual time. It's harder than you think. So with those patients who wake up with symptoms, they'll say, I was fine when I woke up. It's like, well, were you really fine when you woke up? Did you find that you couldn't get out of bed because of weakness or dizziness, or was there other symptoms? And then you go back and say, what time did you go to bed last night? Did you get up in the middle of the night? Those kinds of things, and that will help you get a more accurate last known well. Who did they see and talk to last? So there are many patients who live alone, and what we've found recently, thankfully, a lot of people get checked on at least once or twice a day, and that sometimes goes back to our last known well, and we found that with a couple of stroke patients recently. So the important thing is to dig, and keep asking those questions. What time, if they were out shopping, did the store open? What was the time of a TV show if it was in the evening when these symptoms occurred? When was the last time they had a call or a text from somebody? Last time they spoke to somebody? Interestingly enough, some people can live together and not speak to each other for 2 or 3 hours. And we found that that's happened. So you really have to go back from the last time that somebody saw them well. Or if they had an appointment, was the last time of the appointment. It seems like it's an easy thing to do, but it really does take that amount of interviewing and investigation to really narrow that down. And sometimes you have to use different terms. Like I'll say, when was the last time you were normal? And they will joke and say, oh, that was a week ago, or something like that. So you say, when was baseline? When did you not have symptoms at all? So you have to use different terminology as well. Okay, and it's complicated. So for some patients, they'll say, well, I just seemed off. Or the person with them will say, they just seemed off for the last few hours, and they can't give you that information. That's key. Pay attention to that, because that sometimes can be that prodromal symptom for stroke. They may have had transient symptoms which resolved, and then they had a fixed deficit. That's what you need to know as well. And patients with hemi-neglect, they don't know they have a problem at all. They really won't identify it. Same thing with agnoscosia, of course, tripling over that. Patients deny that they have a problem. So that's something to be aware of, that they don't actually be able to tell you what's going on with them. And you do rely on that somebody else has been with them. So you've got the patient, we've brought them to the hospital, we've worked on a last known well. The next key thing to do is get a neurological assessment, because our goal is to be able to give them TPA as soon as possible. So these are the key things that need to be done. We want to identify the deficits, and we want to continue to evaluate these patients by reassessing them every 15 minutes. Presenting with an acute stroke like symptoms, it's really a neurological emergency. So people will say, do I really have to examine them every 15 minutes? Yeah, you do. This is a sudden onset acute situation, and it's a neurological emergency. And we want to watch for those waxing and waning symptoms to see what goes on with the patient. If the symptoms completely resolve, then you can start the clock again if they have a return of symptoms. So we'll tell people that, you know, they had symptoms, they called 911, we got to the hospital, they got there, their symptoms have resolved. And we see that. So it could have been some tingling, some numbness of an extremity. So completely resolved, we do our testing, and then all of a sudden an hour or two later, they might develop symptoms again. We can start the clock and talk about whether or not we need to look at therapy for these patients. Really important to keep them NPO and to evaluate them for a swallow screening exam. Again, they can have very subtle changes that will cause aspiration, and that's what we want to evaluate. Vital signs as well, every 15 minutes. Again, we consider this a neurological emergency. Excuse me. And then what emergency diagnostic studies really need to be done for these patients? So I've kind of put an asterisk at those that are absolutely necessary. We need to get a head CT. And that's the key thing. And for your facilities, that's the right way to go, is to get a plain head CT. We need to know that because we want to know whether or not they've had a bleed. So we're going to rule out bleed, and then we're going down the arm of an ischemic stroke. The CT can be readily read. It's available. It's quick. It's non-invasive. And it's something that can be easily done for that patient. And it gives key information for your emergency care and where we want to go with this patient. The serum glucose is also a requirement. We want to find out if they're hypoglycemic or not, because we know that's one of the major mimics for stroke. Other laboratory studies can certainly be done. An INR, if you're concerned, we looked at an INR, we can still give TPA as long as the INR is not greater than 1.7. Sometimes we look at a complete blood count. We're not going to delay TPA administration, but if we know the patient has a history or they're receiving treatment for cancer, we'd like to look at a platelet count. An ECG is not necessary, but often we will get that. Don't delay your TPA administration for that. And we look at pulse oximetry just to get their oxygen level and see how they're doing there. But only the brain imaging, the plain head CT, and the glucose are necessary before we think about giving TPA. So what I have here, I know it's a little difficult for you to see this, but what I did, and then Sue kind of referenced this, is I put up what is our workflow from when we look at our patients. And again, I put down both arms of coming in by EMS and coming in by walk-in, because 50% of our patients do come in by walk-in. So, and as Tim also alluded to, we do that brief pause in the hallway. So if a patient comes in by EMS, we call it hot stretcher. They come in, we know ahead of time they're coming in, we have our team waiting there. Again, everyone's on electronic medical records today, so we make sure registration gets the information to immediately get them registered in the system, because having our orders in the system makes everything run better for that. We do a very quick, again, ABCs, and that's the critical piece. If they're unstable, they're gonna go to a room and they're gonna get stabilized first. But if they're stable, the physician or the provider will do a very quick neuro assessment. And really what they're doing is looking at what are the deficits, and are some of these deficits really leading me to think large vessel occlusion, but also are these deficits or something that really impacts this patient's life? They're not mild, they're not minimal. These are really symptoms that could benefit from treatment with TPA. So they're already thinking in their head about giving TPA. And then once we have that, we're going to bring them right by the EMS stretcher down to the CAT scan room for their have their CAT scan done. And then what we do is make sure we're following with an ED stretcher with a monitor on it, and a nurse will go with the patient. So what about the walk-in patients? Well, what we found, we did some studies on this, is that they were having a 20 to 25-minute delay in getting to CT, and that contributed to their delay for receiving TPA as well. So we created what we call a hot wheelchair. So these are patients who are going to come walking into our emergency department into triage. And if they have stroke-like symptoms, we immediately will assess them and either have the provider come out to the waiting room to see them or bring them in a wheelchair around to the provider in the ED, not going into a room, and have them evaluated. And if they determine, yes, these are stroke-like symptoms, I think this patient may be having a stroke, again, a quick assessment of them, a pause to be sure they're stable, and then we'll take them by wheelchair down to CT. And that's really dramatically improved our times to CT. So just something to think about for those patients. And then once we get down to CT, again, that's our priority. If they haven't had lab work done, we're going to draw the lab work there. And then we can hand that off to our phlebotomist. If we do have lab work from EMS, we'll hand that off. Again, get the patient on the CT, perform the CT imaging. and either our radiologist or we'll have our Nighthawk look at that CT image and then move on to CTA. If someone isn't readily available to look at the CT, the ED physician or provider will look at the CT and then we'll move on to CTA. But you do have that time in between the CT and the CTA. We do not give TPA within that time frame in the CT room. A lot of facilities do, and we highly recommend it because it's the quickest that you can do. So that's something to think about. If you're doing that, you're going to need the patient's weight. So you're going to be able to get the patient's weight to do that, and also have somebody available within CT to administer this. But what we're doing between the CT and the CTA, we're getting the patient on the monitor, we're getting a blood pressure, we're doing another neuro assessment to see if there's any change in symptoms. Getting that CTA done, and then determining there, yes. And that's usually when we call down to the ED and say, you need to start mixing your TPA. Once we get the patient back on the ED stretcher, we're going to weigh them then so that they, and I'll call that down as well, even though we're just a minute or two away from our emergency department, so that they can do that calculation. But as Sue has said, absolutely consider, if you know that this patient looks as if they're a large vessel occlusion or they've got significant symptoms and they're going to benefit from TPA, go ahead and mix and have that ready to bolus right in between CT, CTA. That can be done. And looking at those phase 3 target stroke guidelines, that's something that many of us will be moving towards. Again, then, according to this workflow, we return to the ED, collaborate with our physician whether we need to telestroke or not. So on pretty much all of our TPA patients, we do telestroke with a neurologist, unless we have a neurologist in-house who's going to help evaluate those patients. So another just sort of visual that we created at our facility, we call it the Stroke Activation Time Tracker. When we went to our EMR, people still felt as if they needed a visual. They needed something to look at to say, what are my time frames? What do I need to do? And this has been really, really helpful for us. It also helps us with some of our metrics. We do look at a lot of our turnaround times. So the documentation on this is very helpful because the seen by physician time, when they log into the computer to write their note, is when it kind of defaults and it looks like they haven't seen them for 20 minutes and we know they saw them when they came in the door. So when that time is documented here on this paper and I have a signature, I can use that for metrics. But it also is a great way for the staff to keep a visual of what do I need to do. I used to have a little clock on it and kind of put in, when do things need to be done. But what they really wanted was, please remind me how often I'm supposed to do things. When you're in the midst of a neurological emergency, it's helpful to have that checkbox of vitals, neurovitals, and other things that need to be done. So this has been very helpful, and I'm happy to share it with anybody who's interested in it, to have it. So we still have a piece of paper going around. Now, and as I mentioned, we telestroke consult. If you have this available to you, it's really a great resource. You have a specialist in stroke, a neurologist who you consult with. This is what they do day in and day out. They're very good at being able to really help with that differential diagnosis of those subtle symptoms and sometimes vague pieces of your stroke. I also find them incredibly helpful if our last known well is not as clear as we're trying to get. They seem to be able to pinpoint those questions with the patient and family to really find out when was that last known well. So they really help you collaborate on that decision. They'll actually perform an NIH stroke scale with you, which is also helpful. Again, this is something they do day in and day out. They're very good at it. They're very quick at it. You just need to be there to help them with it and really guide the patient to answering questions and to help them with the visual pieces. They'll also calculate the dose of TPA with you if that's needed. So again, mixing the TPA early on is helpful. It's stable for an hour. We do that, and then make sure that you have the accurate calculations for that. And then they do provide guidance on blood pressure management. So we'll talk a little bit about absolute contraindications for TPA, and one of them is hypertension that's not being able to be managed. So telestroke, the neurologist can help you with that management as well. So very key things to move you towards getting the patient TPA. So management of arterial hypertension. So blood pressure elevations are common in these patients when they present. A lot of them have underlying risk factor of hypertension. The stress can certainly add to this, as well as a physiological response for perfusion when they realize that we do have an occlusion in this patient population. Aggressive lowering of the blood pressure is not recommended because of the risk of a worsening stroke. So you do want to maintain that level of what we call permissive hypertension. You need to lower the blood pressure if you're going to treat with TPA, also known as alteplase. And we usually recommend administration of short-acting medications so you can monitor this. We start off with labetalol, can move to a nicardipine drip. Usually when we're telestroke consulting, they'll have us move right to the drip to get good control of that blood pressure very quickly so that we can administer the TPA. And we've done this in a few patients where we're really watching that blood pressure. We've got the bolus in hand, and as soon as we can get that systolic blood pressure below 185, we're ready to bolus that patient. And oftentimes our telestroke neurologist will stay on video with us while we're doing this to help. Excuse me. So again, the goal is for these patients to give the treatment that we have. You know, we've got limited things that we can do for our stroke patients once they're in the midst of an acute stroke, but thrombolysis is one of the options that we have. It's approved medical therapy for carefully selected patients that come in with acute ischemic stroke. So it's FDA approved for treatment if they come in with last known well of less than 3 hours. But guidelines from the American Stroke Association is for treatment that you can do for less than 4.5 hours. Again, we look at our absolute contraindications, and there are some additional contraindications for the 3 to 4.5 hour window. But we know that it improved neurological outcomes, so that's the reason that we're looking to administer this, and also that efficacy is time-linked, so why don't we sure it's administered as quickly as possible, and also to carefully look at our patient selection to minimize hemorrhage. And I know I'm talking quickly, but again, feel free to pop in questions. Alia will manage those and I can answer them along the way. I didn't get into the pharmacokinetics of alteplase, but just want to mention, you know, it stimulates the body's own clot dissolving mechanism by activating plasminogen, which is a naturally occurring substance that's secreted by the endothelial cells. That happens in response to injury to the arterial wall, and that's what contributes to clot formation. Right, so absolute contraindications. So when the patients come in, again, through all of those pieces of the workflow, when you're walking down to CT, when they're getting on the CT table, you're going to be interviewing the patient and asking questions. You know, and I often say to the patients, this is what we do for all our patients. You know, we want to be able to provide you with the best care that we can, and we're going to be, you know, asking you a lot of questions and really bombarding you with questions. So just please understand that this is a standard of care and we want to do our best for you. That really seems to help alleviate some of what's going on because there really are a group of patients coming at them. But again, last known well greater than 4.5 hours, it's an absolute contraindication. If they have a history of an intracranial hemorrhage, absolute, and also platelets less than 100,000. As I mentioned before, an INR greater than 1.7, we won't administer it. If they've had heparin in the prior 48 hours with an elevated APT, and I believe we look greater than 40 seconds, we will not give it. Same thing with low molecular weight heparin in the prior 24 hours. And again, those are not prophylactic doses, those were therapeutic doses. I want to key in on the DOACs, so the direct oral anticoagulants, because a lot of our patients are on these today. But if they have not taken those in the last 48 hours, consider them a candidate for TPA. A case that we had was a patient had a diagnostic cardiac cath and came off of his DOAC and had been off it for 48 hours. Unfortunately, he did throw a clot and did come in with stroke-like symptoms. He didn't come in the time frame for TPA, but it was something for us to kind of trigger to think about that he could have been a candidate had he been in the window for TPA. So keep that in mind. It's an absolute. I actually talked with the patient, say, when was the last time you took this? Uncontrolled hypertension, if they're not responding to the medication, or uncontrolled hypoglycemia. So remember, it's a mimic, but also we want to be able to treat that. And then if they've had stroke or severe head trauma within 3 months. I know Sue will talk a lot about secondary prevention, as she talks different about in our next session. But we do see our patients coming back, unfortunately, and sometimes within that 3 month time frame with symptoms that we aren't able to treat. So, and everyone's concerned, and everyone's, of course, rightly so, our worry is the risk of bleeding. And sometimes you're just holding your breath about, you know, what can I do for this patient? I really want to offer them TPA. I'm so concerned about their risk of bleeding. So we use this visual. It's been helpful to help explain to the patient and their family. I think it's also helpful for the staff to kind of reiterate you know, that 1 in 3 patients receive TPA improve, but 6 out of 100 do have bleeding. Among that, 1 has death or serious disability. So to keep that in mind. But as we look at the patient's presentation and their potential for a serious long-term permanent disability, does the benefit outweigh the risk for them? That's something to keep in mind. And it's a tough decision. We make it, you know, most all the time. And again, we just all just really hold our breath for it. But thankfully, with really thinking about the selection of your patient, you can absolutely minimize the chance of bleeding. Keep in mind stroke mimics, and we see these often. Hypoglycemia, definitely top of the list. You know, they will look like just a stroke. I mean, they do. They come in with weakness. They can have slurred speech. They can even have focal symptoms. Keep that in mind. Any metabolic disturbances. I wanted to talk a little bit about alcohol and also drug misuse and abuse. And caution, don't let this be a distraction, especially in your younger population. We actually waited for, actually was an older patient that came in with their alcohol level was high. We waited for their alcohol level to normalize and their symptoms persisted. They were actually having a stroke. And then we did have a young patient come in their early 20s. First time had used cocaine, came in with stroke-like symptoms. This patient was thought that potentially it could be a vasospasm due to the cocaine. They were actually having a stroke. We didn't treat them, we transferred them. They ended up going down to Boston and they actually had a PFO. So it's really hard to just keep those things in mind. Don't let it be a distraction, just think about that. And I know it's hard, if all you have, is a hammer, everything is a nail, and that's, stroke coordinators think like that. Well, everyone who comes in dizzy is not having a stroke, but we tend to think about those things. Postictal, so patients who post-seizure may have a TODS paralysis. Cerebral infections, so any kind of meningitis can also be a mimic. Drug toxicity, migraines, we see Bell's palsy. I think you're all very good at being able to differentiate that. Sometimes a hypertensive encephalopathy, we've seen this with patients, or epidural hematomas. The key thing to keep in mind, there are times when you are going down the road of this looks like a stroke more than anything else, you may administer TPA. What the literature shows that the risk of bleeding with patients who receive TPA and have not had a stroke is very, very low, just about less than 0.5%. In the past year, we've given TPA to 2 patients who turned out not to have a stroke, but in their acute phase, during that emergency situation, they presented with stroke-like symptoms. And neither patient had any complications for that. So we talked about the absolute contraindications, and then also there are always relative really considerations and warnings that we look at, and those for the 0 to 3 hour window. In the 3 to 4.5 hour window, there are additional relative exclusion criteria. But what I wanted to point out here with the latest guidelines that came out from the American Stroke Association, really in bullet 1 and bullet 4, they want you to consider treatment for those patients because the recent evidence does show that there is not an increased risk of worse outcomes for these patients. So those are the patients that are over 80, or for the patients that have had both diabetes and prior ischemic stroke. So up till about a year ago, those patients would not have received TPA. They now can be considered to receive it. We've been giving TPA to patients over the age of 80. We have an older population in our area, so we are definitely doing that. We also have patients that have a history of diabetes and prior stroke, and we've been giving TPA to these patients as well. So I think what it's done is opened up a population that can now benefit from receiving TPA. However, if they're in this window of 3 to 4.5 hours and their stroke scale is greater than 25, that's a contraindication, as well as taking non-warfarin oral anticoagulants regardless of time since last known well in that window. So those are just things to consider. But it's great to be able to include more patients to consider for treatment. Administration considerations, so just wanted to talk about this a little bit. I also did include at the end as an appendix exactly the steps to administer. I'm not going to go through those, but let me know. Either I can share those at the end during discussion, or I can send you what we have as a step-by-step. TPA is not something you give every day, so it's not something that you can quickly do. The important thing is who mixes it and when do you mix. What we do is make sure that all RNs in our emergency department and critical care unit can mix. The CCU obviously for our inpatient strokes. When do you mix? We mix anytime you're even thinking about this patient might be a candidate. If it's not used, it can be returned to the manufacturer. We don't do that every day, but we do it often when we think this might be. The reason we do that, it does take time to mix this. And again, you want to take your time to do it. It is a lyophilized powder, so it does require reconstitution. You got to be careful not to, make a big foam out of it. So I really do kind of give that to another person and saying, you need to mix while I go to CT with this patient. You want to be sure to perform any necessary invasive procedures prior to initiating the infusion, such as your second IV. It is not automatic that, a urinary catheter goes in. You really want to assess whether or not that's appropriate for your patient, but if so, any invasive procedure prior to it, just to diminish the risk of bleeding if you do have to do that. And again, I'm going to reiterate, you can give TPA if the patient is a thrombectomy candidate. They're going to go to their thrombectomy center to have that, and they will manage their bleeding there. But that don't not give it because you think they may be having an invasive procedure such as a thrombectomy. Go ahead and give it. Using a programmable pump is helpful, especially with a drug library, because that will again be a built-in safety feature for you. A double check. Everybody double checks. Sometimes I'll say 2 people can make the same mistake, but absolutely do a double check on your calculations and as you're programming your pump. Always remove the discharge dose from the vial so it does not get inadvertently administered. Your bolus goes in over 1 minute and your infusion over 60 minutes. And then you're going to monitor this patient for 15 minutes for at least a couple of hours, and then 30 minutes for the next 6 hours. And hours go to the critical care unit for 24 hours. And you want to repeat your NIH stroke scale 2 hours after the infusion. And then a key thing also,
Kathy, you have 5 minutes remaining, just so you know.
Thank you, Alia. A key thing is that if these patients are going to get transferred, be sure that you have that saline flush available to hang if they're going out the door, either when the infusion is just finishing or if the infusion is still infusing. For our setup for pumps, we have 23 mLs of fluid still in the tubing, and that's a lot of medication for some patients. So that needs to be flushed through. So make sure that they have that available or understand that that's an absolute necessity to be done. I'm going to just briefly go over this. There are some dosing calculators out there that are automatic. This saves an incredible amount of time for the one that we use. Talk about complications. Symptomatic intracranial hemorrhage is what we all worry about. So you're going to be monitoring your patient post-infusion. Again, severe headache, acute hypertension, nausea, vomiting, or worsening neurological exam. And that's why we do the exam so often, is that these could potentially be symptomatic intracranial hemorrhage. You're going to want to stop your TPA, do an emergent CT, your reversal agents, cryoprecipitate and TXA, and then a neurosurgical consult. We do not have neurosurgery, so this patient does get transferred. Also watch out for angioedema and orolingual edema. So that is the hypersensitivity to TPA. It's rare, but it happens. Again, just keep an eye on that. And then what I like to say to people is find a way to monitor how you're doing. We participate with Get With The Guidelines, so we do are part of that registry. We're also participate with Joint Commission. So, we're required to look at our turnaround times. But even if you're not required, it's great to give feedback to your staff to say, wow, you got that CT done and the results in 20 minutes. You had the TPA mixed, and we, gave it in 45 minutes. And it's a way to kind of give kudos and recognition back to them about how well they're doing. And post it up on the unit. We have revolving sort of screens that we put information on, and we really let people know how well they're doing. And making those improvements. And sometimes it's also helping to say about, gee, we just didn't make this. I wonder why. And then people can participate in your process improvements. So again, even if you're not required to do it, it's a great thing to be able to do. And then following up on your patients. So looking at their modified Rankin scores to see if they're making improvements. Can't see it as well. This patient, I just want to do a quick case study, had a right MCA occlusion. And it was a 48-year-old patient who came in with a sudden onset of expressive aphasia while she was at work, witnessed by a coworker who called 911. So her last known well was clear. We briefly assessed her and then hot stretched her to CT. She started to deteriorate in CT. We brought her back to the emergency department. She had a right gaze deviation, left arm paralysis. We mixed TPA based on our history. She was a candidate. We did telestroke consult for this patient because we considered her actually a large vessel occlusion. And in 48 minutes, we did administer TPA. We did med flight her to an academic medical center, and she had a successful thrombectomy. And 3 months post, she has a modified rankin of 1, which is pretty much she's independent. And then my second case was just a 90-year-old female. So this was a patient that we really had to dig to get the last known well. We did not make our metric for this. It was 89 minutes to TPA. But this patient really did well with continued just some mild dysarthria. So again, we looked at her for someone over the age of 80. She was in the 3 to 4.5 hour window. And we were able to provide her with that. So who knows, we may be doing strokes in the back of rigs soon or at some point, and some facilities in some areas where they're not close to a hospital are doing this. So just where the future might go, and references are there, and I'm happy to talk about the actual process of mixing TPA if you have questions. So thank you.
Thank you, Kathy. And just so that everybody is on the same page in terms of telestroke, I believe that it's Huggins, Monadnock, AVH, and UCVH has tele-ED, not specific to teleneurology, just so
Okay, good,
that was the feedback we got.
great.
And so we'll take any questions at this time. And then we will move on soon to Sue's presentation on interfacility transportations.
Kathy, I have a quick question, actually. As far as the rule out for history of hemorrhagic stroke or any ICH in the past, is it any time in their history, or is there a time frame, like in the past year or 5 years or whatever?
Good question. I can look that up for you. If there's been a history of intracranial hemorrhage, they're very cautious about administering TPA. The patients that we commonly see are those that have had like an aneurysm in the past, and we do not give it. But yeah, let me look that up for you and see what they have for timeframes. Yeah. The only time that we do consider if there's like a microhemorrhage that was, you know, like a small microhemorrhage as part of a small hemorrhagic transformation that happened way in the past for a previous stroke, we would give TPA. But if they've had an intracranial hemorrhage in the past, we do not. But let me look that up for you, Sue. Good question.
Yeah, thank you. And I only ask because I know that on the secondary stroke prevention end, they're, you know, they are changing some of the guidelines on whether they can get antithrombotics or things like that. So, and I know this was always a question that I would get when I was a coordinator, and I was like, let me so thank you.
Yeah.
Okay, and at this time, there are no further questions besides Sue. So Sue will have your session now. Thank you. Oh, you're on mute, Sue.
Unmute. Okay, can you hear me?
There you go. Yes.
Sorry about that.
That's okay. And you're sharing the screen with the main slide and then also the other slides on the deck. So if you want to choose a different screen, we can see a bigger version of that same slide, or I can share for you.
Nope. Can you? I want to do slideshow. Is that what I'm doing?
Yeah, if you hit the PowerPoint in the lower right-hand corner, right next to the slider that has the percentage zoom, there's a little thing on a stand. If you hit that, it should get us to the full slide view. So next one, right, go to your, there you go. Perfect. Try that. Let's see.
Thank you, sorry.
No problem. No
Okay.
problem.
All right. And I want to thank everyone for being here. This is a really huge thing for us. My background, actually, right, I retired in February, so you're probably like, okay, she's committed clinic nurse. Why is she talking about stroke? I ran the stroke program at St. Joseph Hospital for about 12 years, and then I started a stroke clinic in the outpatient setting as a nurse practitioner provider, which was hugely eye-opening for me. I wish I had done the end of the continuum before I did the beginning of the continuum, because I would have been a better beginning continuum nurse had I known what is happening with the patients once they leave our hospital. So I do have 3 topics. The interfacility transfer was a suggested topic, so I chose that, but the posterior circulation strokes and secondary stroke prevention, I threw those in there. These are topics that we've talked about at a lot of our workshops and our conferences, and I thought that there may be some inpatient providers on the call today, so I wanted to make sure that we did some secondary stroke prevention because that's really key. I have no disclosures. So really quick, interfacility transfer stroke patients, there are some position papers out. One is from the National Association of EMS Physicians, and one is from the American College of Emergency Physicians. And basically what they're talking about is kind of where interfacility transfer, where does it fall, what are the rules around this. So transferring physician has the responsibility really of making the decision on whether the patient's going to be transferred or not. They also have the responsibility of making the decision on what mode of transportation they're going to take. So a lot falls on the transferring physician or provider, but they're the one that is actually with the patient and has the best perspective of making those decisions. The transport service and its medical director are tasked with ensuring that their personnel can actually do the skills that are being asked of them during transfer. So, you know, if the EMS service does not have an appropriate provider to send with the patient, if they don't have providers that have the skill level needed for however critical the patient may be, then they are the ones that need to make that decision on whether they can go or not. There is online medical direction that can be accessed, and that is, again, the transferring provider can access that. They also should be having a conversation with the receiving facility and the receiving providers. And I know when I worked at St. Joe's, we sent a lot of patients to Leahy Clinic. We would contact them very early on, and a lot of times would have a conversation if the patient was kind of, you know, not clear on how critical they were, whether they were a candidate for thrombectomy, etc. We have to always look at our state and regional guidelines. The system within your region or your state is also going to define the scope of practice. And it is important, EMS, you know, should take time at some point to educate the hospitals that they are associated with on what their capabilities are. You know, how many critical care providers do they have? How difficult will it be for the hospital to obtain a critical care provider if needed? So that education is really important. And the other policy statement, just a couple things that are different, is when we're making these decisions, which they're hard. I've been there for multiple decisions on transferring a patient. It's not as easy as we think it could be or should be. It's difficult, but we have to always put the well-being of the patient first. We have to make sure that if we can, that we're pulling in the patient and the family. They need to know the risks and benefits of transferring a patient. This is not a benign thing that we're doing. And a lot of things, if you've ever been on transports, you know that a lot of stuff can happen while you're on them. So the patient and family needs to be aware of that. And also just want to throw in EMTALA there, because the patient does need to have a medical screening done at the initial facility before you're transferring the patient to tertiary care or to a higher level of care. And then the only other thing is, you know, when we have a tertiary care facility that has capabilities that we do not have, they really cannot refuse the patient. It's very good to have those relationships established prior to the transport. But anyway, these are some things to think about when you're going to be transferring a patient. There's a lot that goes into it. So, and I don't know, are we covering the ends of my screen so that we can't see that side, Alia?
No, everybody can see your full slides. Okay. You're all set.
Let's just need them. All right. So we want to set your team up for success. So a big part of the interfacility transfer is pre-hospital care. It all starts at the beginning of the continuum. So it's very important to coordinate with EMS on your pre-hospital processes prior to having to use them. What does your stroke code look like? Your stroke alert, stroke team activation, whatever it is that you call it. EMS needs to be really in the mix on this, and they have to be on the same page with the ED providers and team so that everyone is working from the same page. What's your communication tool? Is it a run sheet? Is there something else that you're expecting them to leave you with the patient information? And a lot of times what we have heard and what we've experienced, I know Dr. Lukovitz has said this a couple of times, that when he gets there to the patient, he hasn't been able to have access to the run sheet at times. He's not 100% sure of what happened in the field. And these are really, really important things. I know I would always try to pick the brain of the EMS providers before they had to leave, after they dropped a patient off, so that we had all the information, because once they're gone, it's very difficult to get that information. So know what your handoff tools are going to be, what you're expecting EMS to leave you for information, and have that all kind of situated before the stroke, the code stroke is happening. EMS should be part of your hospital team. I'm part of the EMS coordinating board, and I know one of the topics that comes up very frequently is that EMS would love feedback from their hospital counterparts. And I know how important this is. So anytime that you can give them feedback, whether it be, great job on this, your timing was great, your Cincinnati stroke scale picked up something that showed exactly what we found on our hospital imaging, or whether it's some opportunities for improvement, that feedback is going to be huge going forward, and they're really hungry for that. They should be invited to your stroke education opportunities. We would do a lot of stroke education at St. Joe's. We would do some specifically for EMS, or we do case studies where we would invite the EMS providers to those particular studies so they could be a part of that. If you have mock stroke codes, they should be involved in that. Your code should start from the pre-hospital piece, and then communicating with the EMS medical director as well. So who's being transferred? I don't know why that is there, to tell you the truth. I don't know if I can get rid of that. Sorry, I don't know why that CAT scan is there. So we know we have limited specialized neurovascular services in New Hampshire. So there's going to be more and more transfers that are happening. We see that multiple hospitals are doing telestroke. So we need to be good at transferring these patients because it's hugely important to their outcome. So what we're, for the most part, seeing critical ischemic strokes, the larger strokes with significant deficits are being transferred, hemorrhagic strokes are being transferred. Those requiring medication or procedure not available at certain hospitals. If you don't have access to TPA, you're going to be transferring those patients. And now our large vessel occlusions, and this is becoming more and more frequent. This study showed that interhospital transfer for endovascular treatment is increasingly common. It's associated with a significant delay in treatment, highlighting the need to develop more efficient stroke systems of care. So multiple groups have looked at endovascular treatment patients who were transferred from another facility or who were within their own facility, and the timeframes are significantly different. Obviously, the patients being transferred from another facility, there's a lot of delays. So the best we can get is going to help our patients and really result in better outcomes. Avoid delays. To me, your mantra is keep calm and keep moving forward. And I saw this in the ED. I went in for all the stroke team activations and would help out. Have some things done before your transfer. So we all know that we're going to be transferring some patients. So to make it the best that we can, do some quality improvement, some performance improvement within your facility. Map out your processes. If you are able to do some mock stroke activations, they're hugely, hugely valuable. They're very difficult because you have to get everybody that's part of the team together to do a mock stroke at the same time on the same day. And so you're asking providers to take time out of their day to do the mock, but it is really, really valuable. And when we did ours, we found a lot of places within our process that we could cut time, and a lot of places that weren't as efficient as they could be. But before I was able to do the mock, I did do a walkthrough kind of on paper. I did it myself. I started from the beginning. I'm a patient walking through. I'm a patient coming in by ambulance or coming in through the emergency department as a walk-in. And I walked through that whole process on my own. And I was able to do a lot of performance improvement from that. So that's good to do before, you know, you have a transfer coming in. But when you're in the moment and you have that patient there that you're considering transferring, keep the flow going. Call your tertiary care facility early, give them a heads up. Every regional conference I've gone to, the level ones, the tertiary care facilities have said, call us, even if you're not sure. If you have any indication that you might be transferring a patient, give us a call. We'd rather hear and not get the patient than not hear and try to get our team, because we have to remember they've got to get their team together as well. CTA on the front end as quickly as possible so you can identify those large vessel occlusion patients. What I observed where the flow stops, at least this may have just been my hospital, but when the patient returned from imaging, I would kind of see things slow down a little bit. People started leaving the room. Now it was maybe one nurse taking care of the patient, but this is where we need to get into transfer mode and really keep things moving along. And then after we made a transfer decision, people are like, okay, the decision's been made, but there's a lot of things that have to happen. We have to remember how many things have to be prepared for that transfer. And there was nothing that drove me crazy more than the EMS providers coming to our facility to bring the patient to another facility, and we weren't ready for them. We need to be ready. So have your documentation, get your discs, you know, if you're sending a disc, make sure that they're burned, get your notes copied. So you've got to be giving people a heads up on this so they're doing that while you're still taking care of the patient. Get report called. And when EMS arrives, remember, they're going to have to switch over their pumps. They may have to switch over monitors. So there's going to be a little bit of time there. I had developed a checklist, and that was really helpful because there were so many steps that we had to remember in this transfer process. And again, throw in questions anytime. I don't mind being interrupted. Decision to transfer, again, it's direct communication between the transferring receiving facilities. Send the imaging as soon as possible, the provider to provider, and you may get a stroke neurologist, or you may get an interventionalist. So they're going to be looking for different information, but make sure that you've got what you need. They're going to want an NIH stroke score, what your neuro exam is, you know, timeline of signs and symptoms last known well, what treatments you've done, reasons for transfer, all of these things they're going to want to know. The patient needs to be stabilized before they go. So resuscitate and stabilize your ABCDs. Again, Kathy talked about the O2 sat. What's the blood sugar? Have you corrected it? If it was below 60, it needs to be corrected. Did the patient need any coagulation reversal? Is this a hemorrhagic stroke, and have you reversed them? Have they had signs and symptoms from TPA? The patient should not be hyperthermic at any point. We know that patients with hyperthermia, stroke patients, do worse. So make sure you're maintaining that. And as far as blood pressure goes, I think this is a key point. There's a lot of different blood pressure parameters that we have to remember depending on the patient condition. And as Kathy stated, we don't want to have any acute or aggressive blood pressure changes. If the patient is not going to be getting TPA, you do not need to treat them unless their BP is greater than 220/120. So these are non-TPA eligible patients and non-bleeds. Okay, this is acute ischemic stroke without bleed or TPA. If they're TPA eligible, as Kathy stated, they need to be below 185/110, and that is pretty hard and fast. And you do literally sit there waiting for that blood pressure to get below there, and you've got your TPA in hand ready to go. If they are an intracranial hemorrhage, you're going to be trying to get them below 140. And, you know, even, I know sometimes we hear 140 to 160, but at the regional conference in Boston in November, there was several studies done, and we had a great speaker who said really 140 is our goal. And if you have a pre-transfer checklist, again, that can be very helpful. These are some, this is from American Heart and Stroke. These are the 2019 guidelines, some of the medications that can be used, and Kathy had referred to a couple of them, but there's a couple others that could be used. They're not quite as commonly used. Mode of transfer, you're either thinking ground or air. Include the patient and family if appropriate. What level of care is needed for this patient? That's going to help you make that decision. You need to look at the distance. How far are you going with the patient? what's the traffic pattern look like? What's the weather availability? We know that the air transport can only fly during certain weather. So there may be some weather that they cannot fly in and you're going to have to go by ground. And does that receiving facility have their own team that they can possibly send? What is difficult and frustrating, and you see it at every hospital, is, you know, having to call around and trying to find, one, a hospital that's going to take your patient, and two, the transportation to get them there. So if you can have some of these processes kind of streamlined before you need to use them, that can be really helpful and cut some time. Again, I don't care if we're cutting seconds, you know, if we can cut minutes, that's fantastic off of this transport to get the patient to definitive care. And then who's going to go with the patient? You need to follow state and regional protocols. What are the protocols for your facility or your service? It's usually recommended to have at least 2 competent personnel or providers there on the transport. And, you know, you also need to make sure for these providers that they've had proper training. You know, they should have ACLS. If they're stroke certified, that's amazing. But we want to make sure that we're sending people that are appropriate for this transfer. 1, for patient care, but 2, not putting the providers in a position that might be difficult for them. Know ahead of time what kind of equipment, drugs, monitoring is going to be needed. You may need to do airway management, ventilation, there may be hemodynamic monitoring, there's infusions that may be running, and you may have to do resuscitation on this patient. So you've got to have all of those things in your rig before you head out. The big thing that we've talked about through the New Hampshire Stroke Collaborative is antihypertensives. If a service is taking TPA that's infusing, and they can do that, once the infusion is up, our EMS services can transfer that patient with the TPA hanging. But they need to be able to provide the same level of care as is required in the emergency department. So they need to make sure that the BP stays below 185/110, and they need to have the medication available to them to be able to do that. You know, if the monitoring process, now Kathy talked about the Q15 minutes, vitals and neuro checks for 2 hours, well, that piece is still going to be in place when this patient leaves with EMS. So EMS needs to be able to continue that Q15 minutes along during the transport. Do they have anticonvulsants? We know that stroke patients can seize. So we want to make sure that these things are available and sent with the patient. And it's obviously good to be looking at these things before the transfer and have them available before the transfer. Also, documentation and safe handover of patient. We know how important safe handover is. It's been a patient safety thing nationally for many, many years. Documentation is huge, but also the verbal report from one provider to the next as the patient goes from one phase to the next. So make sure that you're verbalizing or you're documenting the patient's condition, why they're transferring, who the clinicians are taking care of them, their vital signs, neurosigns, and any treatment that's given during the course of the transfer. You're going to give a good report when you get down to the receiving facility, because they need to know everything that you know, and then your documentation will be handed over at that point. Quality and performance improvement is key. These are things that you do when you have time. This isn't something you're doing during the transfer. This is something that you're doing, you're going to schedule this. You need to make sure, like I said, that you're collaborating with your EMS services, and have a QA process. How are we going to get feedback to you? How are we going to get you involved in some of our education? You also need to collaborate with your tertiary care organizations. Who are you sending these patients to? Have you touched base with them? Have you talked to their providers? Have you talked to their medical director? How you best share images? They should have a just say yes policy. So you're not calling them and they're like, well, sorry, we don't have a bed for you. And then transfer agreements can be really helpful, especially if you want to get the patient back after the acute phase. You know, sometimes the tertiary care facilities do not want to keep patients through their whole convalescent phase. Do you have we had a rehab, an inpatient rehab. So we're always trying, at St. Joe's, we were always trying to get, and Elliott as well, get the patients back so they can rehab with us. So transfer agreements can be helpful with that. Also competencies. You should have pretty consistent competencies between your ED staff and your EMS providers so that people are on the same page. Align your protocols with the American Stroke Association. Retrospective chart reviews are awesome. You should be looking, pick a group. And if you don't have a lot of time, pick a small group, but at least someplace that you can start and say, hey, we're going to look at all of our transfers. We're going to look at whether, you know, we followed the time guides that we have. Did we give TPA appropriately? What was our door in, door out times? You know, did we do the proper imaging? Look at these and include your ED staff in that, the people that were involved in that particular case, and include your EMS providers as well, or your air ambulance. And then to have a stroke champion or stroke team, you know, leader is always very helpful. I did include these are the tri-state guidelines that we have for our EMS protocols for stroke. And I'm not sure if anyone has had a chance to see these. I wanted to put them up for anyone who hasn't seen them. These are developed between New Hampshire, Vermont, and Maine. We do a lot of stroke collaboration between the three states, and Dr. Lukovitz was involved in this as well. I was as well. We had some really great people from all three states. So just looking at we started out with just some signs and symptoms to suspect stroke, the unilateral motor weakness, numbness, dizzy, vertigo, acute visual disturbances, balance, speech, headache, altered mental status. These are all sudden, and I'd actually like to get the word sudden involved in here, but anyway. So we've got that. The EMT standing orders, routine patient care, which really didn't change. And Kathy talked about some of that, and you're all, for the most part, should be familiar with that. So this is what EMS is doing. Standing orders, the IV, and then doing your pre-hospital stroke screen, which for most of New Hampshire, as far as I know, is a Cincinnati stroke screen. Remember, a stroke screen is different than a stroke severity scale, and I'm going to show you that. But this is really important to do this accurately. And I know when I used to review charts, I thought the pre-hospital providers did an awesome job of doing the Cincinnati stroke scale. If you find anything positive, that is a conclusive scale. That's a conclusive screen, rather, sorry. So I want to make sure you remember that, because I'd have people would put it as a non-conclusive screen, but then in their narrative, I would see that they picked up on some aphasia or there was a little bit of drift. If you've got something positive here, that is a positive screen, and you've done an awesome job picking that out, because now you're moving us all forward in the right direction with a suspected stroke. So for what we're going to be doing, we want to roll out FAST ED in New Hampshire. This is the severity score that we have chosen. And that's a whole nother, I can do 2 hours on that, but I just want to show you this. So FAST ED, you're going to look at facial palsy, arm weakness, speech changes, eye deviation, denial, neglect, and you're going to get a score. If the score is equal than or greater to 4, this is considered a high probability for a large vessel occlusion. So what we're trying to do is get the pre-hospital providers, give them more tools out in the field to assess patients and identify those patients that may be more likely to be transferred to a tertiary care facility or may need more definitive care and treatments or procedures. So the stroke severity score, the FAST ED, we had planned to roll that out before COVID-19 came. So I'm not sure now what the what the time frame is going to be. Vicki Blanchard is working with me at the division. The division is very involved in this. So we will get this out. We want to get it out to the EMS providers and also the ED providers. I know a lot of facilities and EMS services are already using this, but we want to make it, again, we want a system of care in New Hampshire, and we want to make it consistent throughout New Hampshire. So I'm showing you this kind of so you can see what's coming up if you're not already using this. We did put some things in for establishing stroke alert criteria. Make sure the glucose is corrected to 60. We want to make sure that there's no chance of head trauma or other mimics, as Kathy talked about, that those have all been ruled out, that the patient has had a positive stroke screen. So you're not going to move on to a stroke severity score unless you've had a positive stroke screen. So all of those things are going to be put into place. And then when you're calling this into the facility, the ED is now getting some information that's giving them a heads up on this is a patient that may need to be transferred, and all of those processes are being put into place. This is kind of, and I'm sorry it's a little small to see, but we kind of put a little bit of a helper on, guiding. So if the pre-hospital stroke screening tool is positive and the FAST-ED is less than 4, then that's looking like a negative LVO, and that can kind of go to the nearest appropriate facility, as your protocols already say. If there's a positive stroke screen and then the stroke severity score is greater than or equal to 4, we're looking at other things. Now we're looking at time. If they're within the time frame for getting TPA, then we should probably think about sending them to the nearest appropriate hospital, because we don't want TPA to be delayed. And again, there's going to be some time frames that we have to think about. How far away is your comprehensive stroke center? How far away is that tertiary care center? If they're close, the patient can go straight there. If they're not, then we want to think about getting TPA in before they're going for their thrombectomy. And then we put in a thrombectomy checklist that people, a thrombolytic checklist, sorry. This is, again, these are things that we want to think about before we're making decisions on TPA. Some pearls for anticoagulants. Again, we want to remember, we pretty much all know warfarin, but do we know the Eliquis, the Xareltos, the Pradaxas, the Sevases that are out there? And we need to recognize those, and there's more coming. So we want to make sure that everyone recognizes those names. And then some pearls at the bottom. Probably the biggest one is if you can bring a witness with you, that would be fantastic. That's so helpful for the ED department. Okay, so that's that. If there's any specific questions on this, I can answer them now. Otherwise, I'm going to kind of keep going. Keep going, Alia. Yeah.
There are no questions at this time. I was wondering, though, if you might be able to think about in the present COVID-19 world. I know that, for instance, ambulances are, I believe, down to 1 provider and 1 driver. So the driver does not need to be a certified provider, and just in terms of reducing exposures in our ambulance systems. So I was wondering if that changes at all any of those interfacility transportation discussions, or any of the discussions that you kind of talked about so far. So
thank you for bringing that up, because the division, the EMS Bureau of New Hampshire has actually put out some modified protocols or new protocols in the COVID world. And one of them is that in emergency situations, that there can just be 1 provider. And I think, yes, I think a lot of this is because I think it's mostly because we want to make sure that we have enough providers to care for all the patients that might need caring for. So that is a protocol that has recently been put out. I'm sure our EMS folks that are listening on this webinar are already aware of that. With this particular situation, the second person can often be a hospital employee. So I think that the transferring providers will need to look at the situation, and it's going to be an individual case. And I think if they have someone that can go, if the patient is critical enough, and whether it's a medication that's needed, if it's something that's hanging, if the EMS providers are not comfortable with the patient, or they don't have the appropriate skills or training at that time, there may need to be a second provider from the hospital that goes with the patient. So I think that's a little bit different than what the division is coming out with for the revised COVID protocols in the field. But again, it's going to be on a case-by-case basis, and I think that's up to the transferring facility to make those decisions on what they're comfortable with. And again, they can pull in the EMS medical director of the service, and they can pull in their receiving facility provider as well. Does that answer your question?
Great. Yeah, perfect. Thank you.
Thank you. So we've talked a lot about posterior circulation strokes in multiple of our workshops and conferences in the past. Recently, I would say in the past 5 years, we've been focusing a lot on this. And this, again, this can be a 1-hour lecture on its own. I only have a few slides, but I did want to throw it out there because these are difficult patients. And I saw a lot of these patients in the stroke clinic. These are the patients, and they comprise about 20% of all strokes, so it's a good number. But these are the patients that are often misdiagnosed, and because of that, there's a delay in care. So these are patients that come in with isolated visual symptoms, and they're sent to their ophthalmologist, and the ophthalmologist sends them back to the emergency department because it's not a ophthalmology issue, it's a central nervous system issue. These are the patients with just dizziness, as Dr. Lukovitz talked about. They're very difficult patients to diagnose. What we did is we did a lot of focused education on posterior circulation strokes, and we started with our triage nurses and we started with our EMS providers, because these are the people that are starting off our stroke continuum. So these are some EMS screening tools, and none of these are evidence-based. They're just tools that can be used in the field that, for me, give EMS providers some extra assessment tools, which I think is really important for them to have. I think the more tools we give them, the better patient care we're going to have all around. And because for me, they're starting off our whole process. And if they're not looking stroke at the patient as a stroke-related patient, then often we're starting to veer off course. And then the emergency department is starting with one vision of a patient, and then they're having to come around and say, oh wait, I think it's a stroke. So if we can give EMS the tools they need to start us off on the right path, then I think the patient overall is going to do better. So SAVE, and again, all of these are pulling in the vision piece and the equilibrium piece, because we know that our FAST tool, face, arms, and speech, that was put together for middle cerebral artery stroke. So that's really primarily for, that will pick up your anterior circulation strokes, but it does not address the posterior circulation strokes. So these screening tools are kind of trying to pull in that equilibrium piece and the vision piece. And then a lot of places are going from FAST to BFAST. We're trying to get away from just the FAST piece, and that's the balance eyes. Sorry, I have a couple little pieces missing off this slide, but you get the gist. So balance and eyes, and then the FAST. And if we're doing that, then we're going to be picking up some of these posterior circulation strokes that are sometimes getting misdiagnosed or delayed. And Dr. Lukovitz talked about the HINTS test, which is really important. You've got to get these patients up in the emergency department. If they are in bed, they may look great and they may feel great. Some of these patients don't exhibit any signs or symptoms or even recognize that they're having any issues till you get them up and try to walk them, and then they start having the symptoms. So you must walk your patients in the emergency department if they're able to, if you're suspecting this posterior circulation stroke pattern, if everything else is looking good. So just a quick, just the A and P of the posterior circulation stroke. This is the cerebellum and the brain stem, and then above the brain stem would be your thalamus, your hippocampus. In stroke clinic, I did see a lot of thalamic strokes, which is why I want to bring that up, because they're very, very difficult. It's all sensory deficit, and it can be very difficult for the patients, and it's very hard to recognize that. In the hospital, it often can get missed. So just quick, you can see the vertebral arteries, they go up to the basilar artery, and then you've got a lot of branches that go out into the cerebellum, up to the thalamus hippocampus, and you do have parts of the occipital and temporal lobes. That's where your vision piece comes in with the posterior circulation. And again, this is just looking at it from the back. You can see the two vertebral arteries that kind of go up through your vertebral area, and then they come together for the basilar artery, and then up above you can see the posterior communicating artery as well. All the red areas are the arteries, the posterior circulation, and the yellow areas are the cranial nerves. So you can see how intertwined the cranial nerves are in this brainstem area, and how close they are to the posterior circulation. So just a little bit of what you can look for when you're trying to assess these patients. And again, we say the emergency department, but these are patients that can be having strokes in-house as well. So anyone who works on the inpatient side, you may be seeing some of these patients, and these would be really key, because we know it's always a little more difficult to be doing stroke assessment and evaluation on the inpatient side. So you're looking for a neuropsychological, such as memory deficits, alexia, which acalculia, agraphia, and
prosopagnosia. So all of these are difficult reading, difficult recognizing words, difficulty calculating, difficulty recognizing familiar faces. These are things that we may not necessarily pick up right away because we're not necessarily asking the patient these questions. We're looking for motor, we're looking for speech, you know, we're looking for drift. But if you're doing your NIH stroke score, we know that this includes the sentences that people need to read, the pictures that they need to be looking at, and the words that we're asking them to identify. So you may be picking up some of these things when you're doing the NIH stroke score. That's why that stroke score is so important, and showing them the pictures, having them trying to read the words, because you might start picking up some of these really, really difficult symptoms that may not necessarily get picked up right away. The thalamic strokes, you're going to see a sensory loss. And I had really quite a few patients that had just an isolated thalamic stroke. They just had sensory loss. Most of it was unilateral. It's difficult for the patient to necessarily recognize this right away, and it's difficult for the providers to recognize it when this is their only symptom, which is why doing a good sensory exam, part of your neuro exam, is really, really important, because you can pick up on this. A lot of these are on the outer aspects of the arms. It may go from the arms to the shoulder, from the shoulder down the arms and down to the fingers. I had some patients, a couple of patients, that it started at the top of the head. They had sensory deficit down their whole right side, all the way down, even into their lower extremities. So that sensory exam is going to be huge. And the sensory loss, none of my patients had a full recovery. And some of these patients I saw for 2 to 3 years. Some of them got slightly better, but none had a full recovery. So this is something really significant. Visual field defects we're going to be looking for, and then the cranial nerve palsies, your classic brainstem syndromes, cross signs where you have some ipsilateral deficits on the face, and then you have contralateral on the opposite side of the lesion will be the motor. You'll notice in the arms and legs. The locked-in syndrome, you know, this is the most significant basilar artery stroke that you can have, where the patient can't do anything but maybe move their eyes, and these patients obviously do not do well. And then top of the basilar syndrome is when you've got the clot is right on the top of the basilar artery. You'll see vertigo, ataxia, nystagmus. So these are some of those atypical symptoms. Again, really quick, you know, the left hemisphere, they'll have the left gaze, but the right visual field deficit, right hemipresis, and sensory loss. And again, it's good to remind patients when they have a right visual field deficit or left, that it's not a problem with their right eye or their left eye, but it's a problem with both eyes on the same side. So the right and left eye both lose their right visual field, or the right and left eye both lose their left visual field. Patients are really surprised when I used to tell them that in stroke clinic. They had no idea. And then the brainstem, you can see some of these unusual symptoms, the nausea, vomiting, again, the vision issues, sensory loss, decreased LOC if you've got a lot of the brainstem involved. If you've got bilateral brainstem strokes, then their patients are going to be more significantly deficit, and then the vital functions are going to be affected. And the cerebellum, if it's a cerebellar stroke, you've got to get them up and they've got to walk. This is just a quick assessment you can do for ataxia, the finger to nose test. You have them touch their nose, then touch your finger. You move your finger around so they have to actually go to the target. And what you'll find with these patients with ataxia, they'll miss their nose, they'll miss your finger, they overshoot, they undershoot. They have a lot of difficulty getting to the target. And then my last piece, I want to do a little bit on secondary stroke prevention. So we know these patients do have a lot of recurrent strokes. I saw it in stroke clinic. I would see patients multiple times for a stroke. And if you look at this, you see that white women are kind of on the top as far as having recurrent stroke. You have 25%. Who's dying from stroke? Again, white women are on the top of that, and that's after 1 year. And then who is dying after 5 years? And again, the white women are the highest. So this was surprising to me when I saw these graphs, because we do a lot of focus on men, but we need to be focusing a lot on our white women as well, and making sure that they're getting the care that they need, the education, the treatment. So this was just a quick study on who gets recurrent stroke. What they found was, and these were all patients who were on dual antiplatelet therapy, they were on aspirin and clopidogrel after their first stroke. Who got a second stroke? These are patients with a high NIH stroke score, patients who had poor blood pressure management, if they had intracranial arterial stenosis, so if they had blockage of any of the intracranial arteries, and if they did not get lipid lowering therapy, these were the patients that were most likely to have recurrent stroke, second or third or fourth. And again, these were patients who were on dual antiplatelet therapy. So if you can find the cause, then you know where to treat them. If we look at what causes stroke, with 20% is large vessel occlusions. I put some little pictures there because I'm a very, very visual person. So the first picture is we're looking at large vessel occlusion. The second picture on the right is small vessel disease. And again, this can be very difficult because sometimes patients have small vessel disease and they'll have these small tiny strokes and microbleeds, and they don't recognize it because their symptoms are so minor and they're so subtle. But what happens is over time there's accumulation of these small vessel strokes, and then the patient does have some significant deficits that they finally seek care for this. This is about 25% of patients. When I would see them in the stroke clinic and I'd go over their imaging, I'd say, you know, do you know that they actually found 3 or 4 strokes on you? You had some old strokes. And people were shocked. But this is what happens with small vessel disease. This is why we focus on blood pressure, managing diabetes as tightly as possible, and managing the cholesterol piece, because when we don't do that, we have the small vessel disease issues occurring. Cardioembolic, most likely AFib, and that's about 20%. And then we have this stroke of other determined causes, which can be only 5%, so it's a small group. But the non-atherosclerotic vasculopathies, we're looking at the dissections, maybe trauma, or fibromuscular dysplasia, which is, they're like segmental areas of occlusion, but it's not atherosclerotic. Hypercoagulable states, these are your patients with your factor V Leiden, antiphospholipid syndromes, and hematologic disorders. These are your patients with sickle cell, prothrombin, things like that. So, you know, it's not a huge population, but we do see these patients that have strokes as well, and we need to find them, and we need to find the cause so we know how to treat them, so we can prevent recurrent stroke. We have 30% of patients that have cryptogenic stroke. We don't find a cause before they leave the hospital. And I think it's important to tell the patients that and to have that conversation, because in stroke clinic, these patients would be like, no one told me why I had a stroke. Well, they didn't tell you because they weren't sure, and we're still going to be doing that workup. So why I think this is important is the workup should start in the hospital, and really we should start thinking about it even in the emergency department when we're thinking about what antithrombotics we're going to be putting these patients on. To say it's a cryptogenic stroke, this is the patient has 2 or more causes that have been identified, so we're not quite sure. Their evaluation in the hospital has been completely negative. We haven't found anything, or they have not had a complete evaluation in the hospital. So we need to continue that on an outpatient basis. These are your cryptogenic stroke patients. What usually we find with these patients eventually, sometimes we don't ever find anything, and I do tell my patients that, so they know. But usually we'll either find occult paroxysmal AFib, so it's so infrequent that it's not even picked up in the hospital if they're on a monitor. We've had patients on a monitor for a week and it's never picked up. What they find is most of these patients don't have AFib until more than 80 days. So you're only going to pick this up on a long-term monitor. So please make sure that, you know, if you're suspecting this, that we're putting the patient on monitoring as an outpatient. The patient might have a PFO, and we will find that on TEE. So if they've had acute ischemic stroke or TIA and a PFO, and you've recognized that in the hospital, and they're not a candidate for anticoagulation, then please start antiplatelets on them. If they acute ischemic stroke with a TIA and a PFO, and you've also noted a venous source of embolism, they have a DVT or something, then they should be on anticoagulation. They should be put on that before discharge. And if they're not a candidate for that, they should have a filter put in. If they have an inherited thrombophilia, Again, we used to check everybody, all the young patients. If they were younger than 50, we'd put them through a hypercoagulable blood workup. And now the ASA, AHA is saying that they're not sure that that screening is even useful, because even when you send them to hematology, they're not always sure what to do with them either. But if you do find factor V or antiphospholipid, you're going to put them on an anticoagulant, which is usually warfarin, or an antiplatelet. And if they have an aortic arch atheroma, which is the other thing that you usually find with the cryptogenic stroke patients, they should be on an antiplatelet and a statin. So real quick, hypertensive guidelines. Always remember, lifestyle modifications are huge. You need to talk to your patients about that. They should be on a single drug. These are patients who have a blood pressure of greater than 140 systolic after the first couple days. If they're greater than 160, they should be on 2 drugs or a combination medication. And again, lifestyle. Resume therapy if they were on it prior to the hospital. If you're not sure, well, the goals are uncertain, but it's reasonable to get them below 140 over 90. And this is going to be huge for a current stroke. If it's a lacunar stroke, you can even shoot for lower than that. If they're older, history of hypertension with a lot of white matter hyperintensity that have been noted on their CT, MRI, you want to just look at them a little more closely. Antithrombotic treatment for acute ischemic stroke, they should be on antiplatelets, not anticoagulation, unless there's some reason, like we found AFib. If they were on aspirin or antiplatelet prior to their stroke and they had a stroke on it, it is reasonable to try a different antiplatelet with them. If you want to try dual antiplatelet therapy, there's been the CHANCE trial, the POINT trial, that both said that dual antiplatelet therapy for the beginning piece after their stroke, it can be very, very helpful to improve outcomes in these patients. Then you can do, let's say, aspirin and clopidogrel for 21 days. And you want to do a loading dose of the clopidogrel, 300 to 600 milligrams, but you really don't want to go any longer than the 21 days. And there are a few studies that actually even say 10 days. But if it's a lacunar stroke, you're not going to be doing this. And if they have coronary artery disease with an unstable angina and AFib, they're probably going to be on an anticoagulant, and you can also put them on an antiplatelet as well. If they've had a dissection, they're still appropriate for an antiplatelet or anticoagulation for 3 to 6 months after that. And even hemorrhagic transformation can have this. Again, we're trying to prevent future strokes. Hyperlipidemia, they need to be on intensive statin therapy. So you're looking at atorvastatin or rosuvastatin. In those dose ranges, that's intensive statin therapy. If they don't tolerate that, you can do moderate therapy, but they should be on a anti-cholesterol medication. A lot of my patients I saw in stroke clinic were not, their lipid panel was out of this, all over the place. And these patients were having strokes, and they were having recurrent stroke as well. If you've got them on max statin and they're still out of range, then you can consider Zetia. And then if you've had both of those on and it's a high risk patient, you can start looking at some of the newer things like Repatha. So prior to discharge, please remember, put the patients on antithrombotics. Again, this should be thought of as soon as possible in the hospital, in the emergency department. You're starting to think about these things. You've got to manage their blood pressure. It's hugely important. Statins, diabetes management, we want to see their A1C, around 6 or so, in the 6 to 6.5 range. Please make sure that they get that. This is another whole thing that I want to talk about, but therapy, they have to go to therapy, speech therapy, occupational therapy, physical therapy. These patients will not improve without therapy. And I saw that I could have done my own study on the patients that refused or didn't go to therapy, and the patients that did. There was a huge difference in their outcomes. Make sure they have an appointment for the PCP or neurology. Otherwise, these people fall through the cracks. Make sure they're getting cryptogenic stroke workup. Make sure that you can order a monitor at discharge or whatever else is needed, and tell them who to contact and when. Otherwise, they're floundering in their, outpatient setting before they see anybody. These are my references, and this is my contact information. I'm so sorry I went through that so quickly and talked so quickly, but please contact me if you have any questions. Working in the stroke clinic was such a great opportunity for me because I got to see what happens to patients. I thought if they left the hospital walking and talking, we did a great job. And I never realized that these patients who have these subtle or sensory deficits or cognitive deficits, their lives have been turned upside down. If they can't add, they can't go back to their job. If they can't work on a computer, they can't go back to their job. And most of these patients are the breadwinners in their family. So it's, you know, it was devastating for me, really, to see patients that I had to start handing out, you know, where to go to the local food pantry because many of these patients were in financial difficulties. So just something to think about at the front end. I wish I had known more when I was at the front end. Thank you. And thank you, Alia, for putting this together. And thank you, Dr. Shute, for all of your work.
All right, so at this time, we'll take one more 5-minute break. Any biological needs that you have, stretching your legs, etc., we'll come back and I'll have a couple of prompting questions for our attendees today, and then any additional questions that you have for either Kathy or Sue, we can take at this time, and then any follow-up questions for Dr. Lukovitz will be communicated to him following the webinar, and he can get back to those who have questions for him. So we'll take one more 5-minute break. Thank you. One of the things that I think would be helpful for the collaborative to understand is what kinds of needs do you all have in your hospitals that may be able to be helped by some collaborative members or discussion. So you could either type in the chat box or you could speak if you have some input on that. And one of the other questions that I think is affecting everybody at this time is how have your hospital practices around stroke care needed to change during this pandemic that may be altering your feeling that the person is getting the best care they possibly could.
We have a quiet group.
Oh.
I can just add a little bit to that question, Alia. So for us, we have 4 rooms with glass doors. We would actually take markers, and if you were in with the patient with just rule out COVID or unsure because we were in full PPE, we would use the marker and write on the door what things we needed, what was going on. It was just a way to communicate without opening the door to the room. So it was a method we used early on. And again, we knew from the EMS report what we might be encountering. People were in full PPE meeting the patient. We alerted CT, so they were in full PPE to maintain the safety of everybody, you know, patients and staff during that time. And the American Stroke Association, Get With The Guidelines, did put out, you know, in the kind of a recommendation that they would understand if TPA was delayed because the need for PPE was required. And that was the kind of a reasonable situation in which you could you know, discuss the reason for delay. So.
And Kathy, is there automatic COVID testing for any stroke patient coming in at your hospital or not at this time?
Early on, if we did test them, again, and I think everybody found this, you sort of went through this kind of how do we test people? So when we initially tested people, then we spent, you know, we used scrubbers. We didn't have negative pressure rooms. So then they had to be in the room with the scrubber for a period of time. So that would delay the CT. So we did test after we performed our diagnostic testing for every stroke patient. We're not doing that today. We do test for anyone who's being admitted, stroke patients that are being admitted. So.
And we do have a comment from Vicki Laufrey at Monadnock. She said, excellent presentations. I think transfer is the biggest issue, at least for us at Monadnock, made worse due to COVID. If there was a way to utilize Juarez that gave updates of the PPS hospitals as to neurology coverage or available resources each day to cut back on some calling.
Oh.
And Donna said that they are treating all patients as if positive for COVID and believe delays are coming from patients wanting to come into EDs. Telehealth, it may be not wanting to come in.
Yeah.
Telehealth is starting and has good and bad points. Elders are not necessarily computer savvy, myself included.
Yeah, we can definitely agree with that. We found a significant drop in patients coming in a timely manner. They eventually did come in, but they were all out of the window for either TPA or thrombectomy. We did find that happening early on. That has since changed. They are now coming back in actually higher numbers. We've had a lot of success with our telehealth, and I'm impressed at some of the savviness of some of our, senior citizen patients, that they're actually doing better than I thought. So that could be regional potentially for what we're seeing that. But the also concern, I think, for rural is, do you have the bandwidth? Do you have the, the ability to connect? Which I know I live in Maine, so rural Maine, we really struggle with bandwidth and connectivity. And there are a lot of older patients who live in those areas.
Yeah, and to Donna's point about I think a lot of people recognize during COVID that the stroke patient population and MI patient population suddenly went down. The EDs weren't seeing these patients. What was going on? And I think we're suspecting that a lot of these people are staying home because they didn't want to go to the ED and get COVID. And I think a lot of national organizations recognize that. I know the AHA, ASA came out with some PSAs that they put out trying to get people to call 911. It's safe, it's important. So I know a lot of national and regional organizations were trying to get that word out to the community. I think it's up to us as well. There may still be people. My parents are in their 80s and I know they're petrified to go anywhere. So I think that's still an issue. And I think that's someplace that EMS can help too when they're, they're in contact with a lot of patients. Hey, it's important to be calling 911. But I think that's a really great point that Donna brought up. I want to make sure that we address the thing before that, and I'm not sure that like giving updates of the PPS hospitals as to neurology coverage. Do we know what that question is or what that answer might be to that? Because I don't want to just blow by that comment. Alia, do you understand what that is?
So you can correct me if I'm wrong, Vicki, but it sounds to me as if what the hospital capabilities are across New Hampshire as opposed to just your typical hospital that you might transfer to. Hold on, there's another comment. So Donna said, agree with Vicki regarding transfer out of Monadnock during COVID. Transfers and census has been down. However, it can be an issue with transfer groups and paramedic availability in rural areas. So it sounds to me, and again, Vicki, correct me if I'm wrong, that further understanding of all the hospital capabilities along this stroke spectrum of care might be helpful for those trying to figure out where to send a patient next that might have greater availability than perhaps, than another hospital that they might send to. So Vicki said some hospitals have only 1 to 2 neuros available and maybe off. So that some sort of system that would update to those hospitals sending would help them to know who is ready to receive instead of wasting calling time, I assume.
Yeah, and that,
Go ahead.
I think that definitely can be a problem. Two things I'm thinking of. One is, I know, and I'm not sure that this would help the hospital per se, but the trauma medical review committee put together a list of capabilities of all the hospitals in New Hampshire. Now, again, this is hard to do because you got to keep it up at all times. You know, if somebody quits, they may not have that capability anymore. But they did put something like that together. I think it's been sent out to the EMS services that kind of says each hospital, you know, do you have a CAT scanner? Are you a trauma designated? Are you stroke certified? Things like that. Do you have neurology? Do you have neurosurgery? I mean, I don't think it would be too hard to do something like that, you know, to give that to the hospitals as well, so that they have at least, but again, it might change a little bit. I know that that's a huge issue, and it is so hard having to make multiple phone calls to find out what's, you know, who has who on that day. But I think that's something that we could bring up to the Stroke Collaborative and see if there's any, you know, brainstorming that we can do around that and see if there's something, because each time you have to make a phone call, it is obviously taking time away from the treatment that the patient's getting.
Yeah. And I attend the Trauma Medical Review Committee meeting, so I could certainly bring that up. This is also one of those times, I think, where, as you were saying, Sue, speaking to your EMS providers that you regularly have as sending agencies is really helpful. Just like similar to the secure trainings that many of the critical access hospitals did, where it was trying to improve the response time for a behavioral health incident. This kind of communication across the spectrum of all the different providers that touch your patient, those conversations can be really helpful. So EMS in this case may know more about who has what at any given time. But Donna said, we transfer to CMC, Dartmouth, or Mass. We typically do not admit to our facility with TPA administration. And then Ruth said that, thank you, Kathy and Sue, for this presentation. Alia, thank you for including us. Look forward to future educational opportunities.
Awesome.
And then Vicki said that would be great to have that info for New Hampshire, especially when with only two nurses on at night in the ED trying to call everywhere. So,
I mean,
yeah.
that's like, how do you do that? You're trying to take care of patients, you're trying to make phone calls. So
Yeah.
That's amazing.
Yeah.
And I do really want to acknowledge everybody who attended today. It was really awesome to see that there were 16 people who committed to attending, and then we got every person that said that they would attend. So that is really a testament to your efforts on your end as attendees. So I really appreciate it. And certainly if there are other things that come up in terms of what you'd like to know or learn that might be helpful from the collaborative, let us know. And also I have been working to try to figure out how we might be able to teleconference for any upcoming workshops and conferences that do happen in person, which will probably be a while, but I will certainly keep all of those who attended today informed of any additional opportunities for education. So
yeah, and I mean, please reach out to any of us at the Stroke Collaborative. What we love is to be able to support in any way, education, whatever it is, sharing protocols. We have a website on the NEC website, which is the Northeast Cerebrovascular Consortium, where we have some protocols that we've posted from St. Joe's Hospital, Concord Hospital, Wentworth Douglas. So we love to share. So please, let us know if there's anything that we can ever share. It doesn't even have to be an official educational opportunity like this. It can be one-on-one conversation or whatever. So.
And I second that as well, Sue. So please reach out.
Well, thank you very much. Before we lose too many people who are heading off for their day, I appreciate your time, and thank you very much to Kathy and Sue and to Dr. Lukovitz for presenting, and we look forward to further opportunities for all of us. Thank you so much. Have a great day.
Thank you.
Thanks, Alia. Really great job. Thank you.